Reduction, majority of these patients we treat surgically. Beyond that, most of them goes with the plaster cast, depending on whatever we have discussed in the morning session, and they go with some malunion. Those patients who are symptomatic comes to you for a further treatment. So why malunion happens? Two possible reasons. You missed it, you underdiagnosed, or you missed it. And after doing all those things, still do we have a chance to correct it? So let's have a look with the case-based interactive discussion. So this is a young female patient who was treated with the plaster cast for 6 weeks, below elbow cast, and then again went for a physio. She is an enthusiast cyclist and right hand dominance. She has a good flexion, extension. Grip is also okay. But what is her problem is restriction of supination. The opposite side has a full supination. The injured side at 10 weeks duration, supination is restricted. And as I said, she is an enthusiast cyclist, not a weekend warrior. So she wants that function. So how to proceed from here? 10 weeks of duration, restricted supination. Any other investigation to proceed further? All right. Done CT. So you can see there is a volar facet malunion. Another view. Tear is in congress. This is the 3D. So now you know there is a malunited volar facet, restricted supination. So how to proceed further? If at all you want to do a surgery, so what implant, what approach, or should we leave her alone?
In that lateral view, why that lunate is looking VC? Volar, X-ray. Lateral X-ray. Previous.
That is
why the lunate is looking flexed as a VC? That's what I was asking you.
Lunate facet has gone down and malunited. So how to proceed? Whether to offer a surgery or should we leave her alone? And if at all surgery, then what approach, what implant? And it's 10 weeks duration from the injury now.
I think the sigmoid knot itself is in a malunion there, as we see the CT scan on the left side.
Yes.
So therefore it is articulating with the distal ulna, is it not? So that is the cause of limitation of supination, I think. So unless you articulate that with the sigmoid knots properly, I don't think that she'll get supination. Your CT scan is quite clear on the left side, the coronal view, the axial view.
And
This one?
Yes. So then what approach if you want to offer a surgery? Yeah.
Before that, sir, if you see the actual image, the bottom part is the dorsum and the top part is the volar. Is that right? Correct. So here, the reason for restricted supination is not so much of malunion or an impingement in the DRUJ, but it is a capsular contracture. Okay. There is no mechanical block to supination here. Yeah, that is because of the soft tissue contracture probably associated with the fragment. Possibly, yes.
Which she has done already, which she has done almost more than 8 to 10 weeks.
No, not every contractor has to respond to stretching. I'm just making a point that there is no bony reason for lack of supination.
So how to proceed? Should we leave her?
Certainly not.
So then what approach, what implant, and how to proceed? Anyone? Okay. I'll come back to what we did to that patient. So here is another patient with a similar kind of injury, treated surgically on day one itself. And he is a bouncer by profession. So this was his post-op X-ray.
No, it is not captured. His bones also bounced.
And he's bouncing from one doctor to another doctor. So again, good flexion, good extension, radial ulnar deviation. What is affected is supination. So is it soft tissue contracture or something else?
Inflammation and supination, both are seen in this.
Yes.
Pronation and supination, both. So which is affected? Yeah.
Supination, not here. So the second patient, as I said, is bouncing from one surgeon to another surgeon. So went somewhere, I don't know.
You know where.
Yes.
Straight to one.
All, yes.
To the physiotherapist.
So the first patient stayed. So plan was to go between the palmaris longus and FCU so that you can directly approach the volar lunate facet to do intra-articular osteotomy and fixation of that fragment with the specific implant. So this was intraoperative pictures, FCU, PL, retracted, and this was the fragment. So this is the proximal forearm hand here, and we did the capsulotomy so that we can see intra-articular reduction. This was the reduction achieved. And we fix with the hook plate, which is specifically designed for these type of fracture. So C-arm images, 3 weeks post-surgery. Within 3 weeks, she completely gained her complete supination. So 3 years follow-up, full supination, full flexion, and she joined back her passion to ride the cycle.
So as Pankaj sir said, there
Yeah.
was no bony block to the supination. So you did anything else apart from the corrective osteotomy and fixing it properly? Any release or anything like that?
No release. So your approach itself released everything because that's an intra-articular. So you have to see the articular reduction.
So your cause for that was bony malunion, is it not?
Yes,
Ah,
that was corrected post-surgery. So this was one of the literature which, published maximum 13 patients of average age 44. And the most important thing is the osteotomy they did is at almost close to 5.5 months. So still, even if you miss the bus, you still have a chance for longer duration. And importantly, the supination is improved more than 50%, which is quite significant. So let's move to another case. This was the initial and this was post-operative period. 1K wire and plaster, then again 4 months for post-injury. So volar subluxation was a volar Barton, which is now malunited. And this was her clinical picture. Entire carpus is subluxated volarly. And that was also relatively painful. So, how to proceed? Anyone?
What is the duration now?
4 months from the injury. She is a nurse at some hospital. I'll show you another case. Maybe we can discuss both together. Male patient treated conservatively in plaster for 6 weeks. 1 month post-injury, 4 month post-injury, grossly restricted supination, painful, and again entire carpus is volarly subluxated. This was the X-ray, CT. So one was operated, similar X-ray. One is treated conservatively. Both have same problem. Malunion, volar Barton, and the entire corpus is subluxated. And more or less similar time duration, 4 months from the injury. How to proceed now?
So both requires open volar exposure and corrective osteotomy at the malunion side. Though case number 3, there I think the margin of the fragment looks too distal. But yes, once you reduce it properly, then we will come to
CT
know.
is quite big. Yeah. X-ray it is. That's actually CT image.
What would happen if we leave them alone? What would happen if one leaves these kind of patients alone?
Probably
Case number 3, the range of motion and everything is good. There is only a subluxation. So what would be, is there any natural history in these cases?
intra-articular malunion, for sure, they will lead to arthritis. Some more day, a year or 2 years, or whatever time, they will develop arthritis and may land up into breast fusion.
What is the pathology of restriction of supination here?
Again, same arc.
No, that was intra-articular sigmoid notch. Here the ulna is subluxated, so it's no more articulating with the distal radius. So as in old people, they have good supination for malunited collosis fracture. So what is the cause here?
This one is the entire corpus, the coronal shear has gone down. So there is not, the ulnar head is not making a complete, 360-degree articulation here, arch here. The same with the other case, one which is operated and one which is conserved. So our plan was to go intra-articular again, did the osteotomy. For both the patients, similar approach was used. Temporary fixation, plate, and this was the outcome at 8 weeks duration. Similar to the case number 4, got a good functional recovery. Moving to another case, young female patient treated conservatively. Someone planned to do extra-articular osteotomy, bone graft, and plating. So this was the immediate post-surgery. Any comments? So this was immediate post-op, and this was after 6 months.
Why was the dorsal plating done here?
Received with this, like this.
This highlights the fact what Nikita said, that these plates are extremely weak plates. So if you use them and you bend them, that is a weak point, and you need to protect it until healing. Or if you start early mobilization, you can end up with a breakage like this.
But does that mean that you would still use a dorsal plate for a malunion for distal radius, or would you rather want to go volarly if you are fixing it?
You want to take that?
No. So good. So again, yes, you can do that, but again, you have to protect. These are not a sturdy plate, not the which are actually made for a dorsal or a volar.
Just a quick this thing to that. When you have a wedge which is wider on the dorsal side, that is your corrective wedge is wider on the dorsal side. If you go from the volar side, how will you put a wider piece of bone to go behind? Then it's easier to go from the dorsum. So that's what's been done there. I wouldn't question that. What I would question is the fact that he's bent the plate a bit too much. That probably this is my case. I don't know. It looks very much like one of mine. But the other thing is abnormal bending of the old plates has led to a lot of disasters. So you need to be very careful when you're bending the plates.
So extremely painful, entire carpus is subluxated volarly. Keloid also develop. So what to do next?
You have to remove the dorsal plate first.
Okay.
Dorsal plate has to be removed. And now volar fixation.
Okay.
What could be the cause of pain?
Malunion height is too much. DRVJ. So radial length is also increased. Okay. So I'll just quickly move. So we removed it. Went on volar side. Put in a graft. Try to restore. And this was the function that we got. This was, patient is far, so got this much. Young female patient, bilateral distal radius fracture.
Unit to reproduce.
Content writer by profession.
And I think case discussion करते हैं मेरा infection हटा देते हैं.
So how would you treat this on day 1? Bilateral distal radius. It's a closed fracture, no open. Anyone?
Some more X-rays I would like to see. Definitely.
As of now,
X-rays or some traction view. Because obviously she requires surgery. It looks extra-articular, both sides. Some more X-rays, some more information would be definitely appreciated. But probably if it is more on the volar side, less on the dorsal side, because it is bilateral, the situation is urgent. So you require plating on both sides.
okay.
If the things seem to be going out of hand, because this is not a case for spanning plate, definitely.
Yeah.
Or I would not use it, think of external fixator and all these things. It is bilateral and she's using the laptop whole day. I think probably a good, well applied volar plates, ideally same sitting will also help her. But some more information would be worth it.
This was done. Any comments?
Prashant, when you put the X-fix now and when you see a sizable distal radius, would you plate it right now? I mean, you must have
was
done
in the
elsewhere.
past.
Okay.
She had come to me after like 7-8 months.
Okay.
X-fix done by primary surgeon.
Okay.
On the right side looks very distracted. Radiocarpal space. Undergo CRT.
So this was the X-ray when everything is removed. 6 months post-injury. Still she is symptomatic on both the side.
What symptoms?
One,
Rotation or hand?
both. So our symptoms, this is our resident's relative. No supination. She has that click every time when she does pronation, supination. And the actual problem, what she is facing, not able to wash the face, not able to do her day-to-day activity. Like sir mentioned, this is the last thing which she has clearly mentioned. So when I saw her left side, so there is a click, ulnar head prominence, ballotment was positive in all the pronation, supination. So she went on, we did the MR, there was TFCC foveal tear, which was repaired, transosseous suture. And left side was non-dominant. So we just excise the distal part of the ulna. And she has got full flexion and extension. This is almost now 2 years from the surgery.
I heard sutured at TFCC, basic CD question. So where is the attachment of the ulnar aspect of the ulnar part of the TFCC?
So to make it simple, there are two attachments. At the tip of ulnar styloid, the superficial fiber of TFCC are attached, and at the base where styloid is attached, the deep foveal fibers are attached, which are major stabilizers of your DRJ. And like what earlier discussed, if you have ballotment throughout the pronation, supination, then you need to fix that ulnar styloid. So how much
I had
time?
a complaint of deep grip. So is this addressing that? She in the WhatsApp she said grips are weak.
Yes.
Direct is supposed to become the grip further.
So that addressed the pronation and supination. That was on left side, which is her non-dominant hand. Right side we repaired the TFCC. So quickly we'll
Without the radial alignment.
For
Side you sutured the TFCC, but
the right side problem was only ballotment. There was
but
no
the
other
radio
problem.
ulnar, the variance and all was gone haywire, no, the right side. Can you go
Yes,
back on the?
but that was not the cause of the problem.
Can you go back on the X-ray if you have time?
Right side.
Right side. For our understanding, see now here you have done only the scopic management, right?
Right.
But
Yes,
this right side picture is right side, right? So the radial nerve. No, this side is right side, no? The second and the fourth picture are right, you know. Second picture is right, no? The radial, I mean, the relation has gone haywire without aligning it. I have not understood. Just for my understanding, you have repaired only the TFCC, but that is without aligning the radius and
because other
relation.
parameters are not symptomatic. If she has a ballotment, that is indicating that DRUJ is unstable. She has a good flexion, she has a good extension, she has pronation supination, except that click which is during the pronation and supination.
So your surgery on the right was for ballotment
Yes,
only.
yeah.
So probably the achieving the radial height would have made the DRUJ stable. Yeah.
Yes. Yes.
I mean, not in this way. We have all these tendon slips described.
Yeah.
Take it around the ulna and suture it back.
So that is like when
They
you
work or-
completely, open and when you want
they
to
work
prevent
or-
the future dorsal subluxation of resected stump, that you can do a dynamic stabilization process. That I would do it on a right side more dominant hand, where you can have a later on problem where the proximal stump migrating toward the radius.
And
Yes, sir.
On non-dominant hand,
another one
not
small-
required.
I'm just asking, pardon me for all these silly questions. Between the Dirax and the Saukapanji, in this patient, in this age group with this activity, which would be better?
I'm coming to the next slide. So I'll quickly go through it. 4 years back, managed with plate, restricted dorsiflexion, palmar flexion, grip strength, pronation, supination is also grossly restricted. And this this boy had left side some muscle weakness since birth. Left side is grip poor, spastic hand, and the right side he got fractured, and 4 years after he was symptomatic. So plate is gone into radiocarpal space. So this is the Saukapanji, where DRUJ was fused, and there was some range of motion at mid-carpal joint, which was preserved. So this was his range.
Range is good, but the waist is not. Waist is subluxed.
Yes, but we
It looks like nature.
To answer the question that you asked, between a Dirax and a Saukapanji, how do you select? If beyond the bone, between the carpus and the bone, that means the TFCC and everything else is good, a Saukapanji works. If that is destroyed, you bring this together, the TFCC is going to give you pain, so you need to just take it out. So then a Dirax works.
Partner, sir, this lecture on the middle substrate. Can you just
Yeah,
the distal excision of the distal?
yeah, it's actually a very simple procedure. You just resect a segment of the ulna that works, that takes care of everything.
everything, yes.
I think Saukapanji is probably not really required in many cases. All the TFCC, everything will heal on their own once the pressure on the ulna reduces. So my experience of Milch osteotomy is very good. I have a low threshold of doing that. I'll do it if there is any suspected, if I suspect that patient is not going to recover painless forearm rotation, I just do a Milch right on the table. and that works very well. And I keep the hand in supination.
One. So quickly, how to prevent the malunion? Get X-rays, get additional images if required. Know your approach based on your X-ray CT configuration. Know your implants. Get a good reduction. Certainly, this is not accepted. What implants you are going to choose? Don't put, as it is, volar plate on dorsal side. Big red flags. Fragment specific fixation, if you have that type of fracture configuration. Ideal plate length, we have discussed early in the morning. Views, again, we have discussed. 3-4 cases, you must know that you will not miss the lunate facet. So all those things one should not miss when you are putting or treating any distal radius fractures. And again, the most important, not all radiological malunion requires treatment. Please correlate clinically. So this is something which keeps on
Not very different from my consulting room. Same noises come.
board certified.
I think this was pretty common. The hard Vaidya concept is pretty, I don't know how here it has reduced. But hard Vaidya is still there. It was my area also. Yeah. Hard Vaidya is very much a concept. In fact, there is from KEM, I remember when you come out from KEM, you go straight on the main road, there the hard Vaidya. But it's become a orthopedic surgery. You know?